so you can see your screen.
Okay, thank you. So good evening, everyone. So me, I'm still a beginner, really. So this presentation, I made it basically mostly for myself, but you guys, you can join me in the journey, just trying to learn, to see the first things that I need to know about the basic aspects of laparoscopy. So I really started the basic part. I had a bit of issues with how to put it across, initially thinking maybe I should put some video clips, but technology put a bit of some breaks in there. So I tried to put up something that you guys maybe we can make some sense at the end of it. So basically, when you're looking at abdominal entry, there are about 3 basic techniques. So basically, it's open and close, and then which is more like a hybrid, which is the direct optical entry. So in the closed entry, we are looking at using ferrous needle to go in. You get a pneumoperitoneum, and then you can introduce your trocar. Whereas the open technique, we are using mostly the Hasson technique, and then the direct optical entry, which is coming in now more these days, which is basically a combination of both the closed and open technique. So with using the ferrous needle, we all are aware of the ferrous needle, that it is a spring-loaded blind needle, which is introduced at an angle of 45 degrees onto the patient's abdomen. It has its separate features, which it gives you a tactile feel where you have the double click, where you penetrate your sheath and your peritoneum. And there's additional safety measures to see whether you're actually inside the peritoneal cavity. You can do the drop test, where you put a drop of fluid in through the port and elevate the anterior abdominal wall. So when you get that suctioning effect, if you're in the abdomen, increase your negative, you put your negative pressure, the drop will go in and it will tell you that you're in the right place. The risk, because this is blind entry, so risk of visceral injury and blood vessel sufflate into the wrong spaces. So this is the ferrous needle. We are all aware of it. Basically, that's how it looks like with the here, the lever on top and the fixation ring and the flexor, and the grip where you grip so that you can control the drop, and the cannula which enters into the abdominal cavity. And here you can show the housing there. This is a cross section of it. And you can see here the tip of it, which is essentially blind ended. So with the Hasson technique or the open technique, this is where you open the skin, identify the sheath, and the sheath is opened under direct vision, and the peritoneal cavity is entered as well under direct vision. So there is a custom-made Hasson trocar, which is then inserted. It is a blunt trocar, and through which, and the Hasson trocar also has got kind of like a balloon there, which helps with keeping it tight, so that there is no leakage of carbon dioxide, of air. So the benefits are, you definitely get certain entry into the peritoneal cavity. It reduces risk of bowel injury. However, if the incision done by the surgeon is too large, it can leak. So it may need maybe for someone then to put up maybe like a figure of 8, or maybe to put maybe a pest string around, just to maintain the airtight environment and not lose your pneumoperitoneum. So right, this is what a Hasson trocar looks like. So that is for direct entry, and you can see that it is blunt here, and it has got a balloon which you can use to help increase your your airtight space. And this is how it will sit when you open in. After it has been opened, it will go and sit now at the way here on the tip is inside the peritoneal cavity, and the balloon is sitting just under the parietal peritoneum here and causing your seal nicely. So the direct optical entry technique. So they are nowadays, so they are now specific trocars, which are also blunt-ended, where you can use with a 0-degree camera lens. So once you have opened the skin, the initial incision on your skin, then you can go in just like in a blind method. But the difference now is because of your special trocar, it allows you to be able to see with your 0-degree camera lens or the length or the layers of the abdominal cavity as you go in until you get into the peritoneal cavity. So once you have done that, then you can remove the trocar, put in your camera and insufflate at the same time, connect your gases and insufflate at the same time. So this one is basically a hybrid of both the blind entry, because you go in just like with the first needle, and it's also under direct vision because the camera allows you to see at every stage where you are. So its advantage is, one, you don't have to make a very big incision by any mistake. Number two, your risk of injuring bowel is reduced because you are seeing everything is under direct vision. So these are the trocars, examples of the trocars that are available. There are various sizes of thicknesses, diameters of the cameras. So, but also the trocars come in various sizes as well. So the other thing which I thought maybe we should look at as well is everybody just, this umbilical incision, everybody just assumes that when you go in umbilicus, possibly, maybe not everyone, but people may just assume that when you go into the umbilicus, it's only one area where you can actually just incise. But there are various areas, various incisions. Some go directly onto the umbilicus itself and incise there, and some go supraumbilical, some go infraumbilical, some like longitudinal incisions, some they like lateral incisions. So the main issue with the if you go onto the umbilicus itself is it depends with how the umbilicus looks. Some of the umbilicus are infected, some there's risk of infection, bleeding. On healing, they may not heal very well. There can be keloid formation. There can be hernia formation as well. So maybe that's why maybe some people prefer to go slightly above the umbilicus or slightly below to access entry. And another consideration is insufflation pressures. Not every patient, there is no magic number for per se to say every patient needs to get. We know that 15 millimeters is more or less our reference pressure that we should maintain inside the abdomen. But the recommendations is try to use as minimal pressure as possible. That gives you as much vision as possible. So because the dangers of overinflating is it will affect your procedure in the sense that you may not be able to see that you may have caused vascular injuries, or even when you are suturing, and you may not be able to identify that you do not have good hemostasis, because the pressures, they are causing a tamponade on your vessels. So after you deflate now and you are coming out, the patient can actually bleed and can give you a problem. So underinflating also affects your vision, and the obvious attendant risk of visceral injuries. So yeah, so the trick is try go as low as possible, but with as much with adequate visibility of your operating area. So then the other thing that I thought maybe would be good to look at is ports placement. And there are many techniques for putting ports. And this is, it depends on somebody's comfort. This is the level of ability, the type of surgery that is being done, the complexity, and the number of assistants that are available, the assistant ability. And so I've put in a few examples within that we're going to just go through and later on discuss together and see how best maybe people can look at it. So for what I've in my short period of laparoscopic work is the procedure depends on a variety of factors, of which chief is the comfort, the ergonomic position, how comfortable you are. Because once you start getting tired, once you start getting uncomfortable, it affects the longevity of the period, the time that you can take to do the procedure. And also it can have implications on the outcomes. And also you need to be able to site your posts in the way you get good access to your operating site, either left, right, or either side of the patient, of the patient's pelvis. And that will also affect your ability to dissect, ability to suture. And also you have to take into consideration the quality of your assistant or how many assistants you need. So if in a lot of cases, maybe you are dealing with basic assistants who at the best they know just how to hold the camera still. So it may affect how many ports you need to put, and possibly even what type of surgery, the complexity of surgery that you need to do. So in a case like this, where this is a 3-port technique, which is possibly the most basic that most of us we get acquainted to first time, is where you put, obviously your camera port is on the umbilical level, and then you put your port A and port B. So in this case, the assistant is just holding the camera, and the surgeon is holding the instruments. So the right hand of the surgeon, assuming that the surgeon is right-handed and is operating from the left side of the patient, is holding B, and the left hand is holding A. So this one, it allows, if you can see on this figure here, where there are some figurines to show you, this is how the position is actually achieved, where this one is the main surgeon and this is the assistant, and this is where the position of the surgeon is. So your port B is here, port A is here, and your camera port is there. So first, sorry. I need to go back. How do I, okay. Okay, so it's used in easy cases where we don't need another port for you. It is, let's say, like you're doing just like an ectopic or a laparoscopic tubal ligation. So you don't need, there's not much benefit in introducing a third port. And then there is, if you have an incompetent assistant who cannot use both hands to one hold the camera and still use the other port to give you, to assist you. Its advantages, obviously, is for the patient. The patient feels that at the end of the day, the procedure was done. There were not many scars to deal with. But however, the disadvantages, it limits the complexity of cases that you can do, and it also may force your time to do the surgery to be prolonged. So this is a variation of a 3-port technique again. So you can see the initial one was a bit higher, and this one is much lower here, the positioning. And here, the advantage is it gives you a bit more ergonomic position where your hands are lower. You can put your hands closer to yourself, and it's more it can be more comfortable. So the 4-port strategy, so you've got your contralateral ports, and you've got, which are they're on the other side of the patient where the surgeon is on one side, and you have ipsilateral ports which are on the same side as the surgeon is standing, and then you have got your suprapubic port where you have got the fourth port as in the midline position. So we'll discuss each one of them individually. So this is a diagrammatic presentation of a contralateral port, where obviously our camera is at the umbilicus. So you have your A, which is here where the surgeon is here on the left-hand side, and you've got A, which is on the left-hand side of the patient, and you have B, which is on the right-hand side, and C. So A and B are your surgeon's main primary ports that he's using. And this one, C here, is the port that the assistant is using. So the assistant is holding both the camera and the port C. So the right hand of the surgeon is on port B and the left hand is on port A. So this allows so this is another variation again of a contralateral. So you have port A and B, and then you have C. So the difference with the initial one is with this one, you now need two assistants. You have one assistant who is holding the camera, and you have the second assistant who is holding the instrument going through port C, and the surgeon still has the two primary ports here, A and B. So the advantages here is it is easy to tie knots because your instruments, they are at right angle to each other. And you can actually dissect both sides of the pelvis easily because your instruments are on either side. You can right hand can dissect the right side of the pelvis, and the left hand can dissect the left side of the pelvis. However, the main issue is because your hands are adducted and they are, so it is easy for fatigue to happen easily in both arms. And because also your right hand is reaching across the midline, you can interfere with the camera, with the assistant who is holding the camera. And of course, for shorter surgeons who have got reduced reach, it can be a bit of a difficult placement position for them, this contralateral position. So then we look at the suprapubic port. So this is a diagrammatic presentation of a suprapubic port where you have your A and B again in the same classical, I can call them classical position, and you have your port C in the midline here, and still have our camera within still the same position. So here, the difference now is the surgeon's right hand now, it can go, is in the midline. So the midline, the middle port, the suprapubic port, which is positioned classically between the midway between the pubic rama symphysis pubis and the umbilicus. So it gives access to both sides of the pelvis. So the surgeon can operate on both sides, still on both sides of the pelvis. So what can happen is even if the surgeon can actually go to the left side and work on the left side of the patient, and if they want to work on the right side, can go around and operate on the right side of the patient, and still they don't have to put on extra ports. They can still use the same ports to do that. So it also allows for the assistant to be able to suture from the right side if the assistant is competent enough. And yeah, so the problem is because of the position of the suprapubic port, it is difficult to suture, especially like for uterine incisions, like where there is, like, let's say you've done a myomectomy, a laparoscopic myomectomy, and they are closing a transverse uterine incision, or they are parallel vaginal wall incision. It is very difficult to suture because of the position of the suprapubic port. So these are variations again to the suprapubic. So this port C, which is the suprapubic port, remains in the position, but here port A and B can be brought lower and for improved ergonomics as well.
This is another variation where port B, the suprapubic, is brought much lower down, and port C and A are remaining in the more classical position. The disadvantage of this one is it does not give you access to the rest of the pelvis because it is too low for you to be able to work with it. And this is another a variation again way of the positioning. Okay. So when we look at ipsilateral ports, ipsilateral ports, they are on the main operating ports are on the same side as the surgeon. So you've got our ports here. What they do is on the ipsilateral ports, because they are closer to the patient. The surgeon can put the hands lower, and they are in an adducted position closer to his body. Can allows him to be more flexible and to actually reduces fatigue and lethargy while operating. So that is the main benefit. However, the disadvantages are because the instruments are parallel to each other, it is difficult to tie nose parallel and close to each other. And you have access to one side of the patient. So like in this case, you have access to the left side of the patient's pelvis. And on the right side, it's quite difficult to have proper access on the right side of this patient, especially in this variation of the patient. So now how it would help is the other variation which improves your access to the pelvis is you lift up the ports, insertion of ports, instead to be much lower down in the pelvis, put them higher. And like you can see, the ports are this is anterior superior leg spine, and this is the umbilicus. You draw a line and you put them at that level, on that line between anterior superior iliac spine and the umbilicus. So it allows for you to be able to approach the pelvis in a better way than much lower there. Than the much lower insertion of the ports. And this is another variation where you can go onto the other side. The surgeon operates on the other side and it's pretty much put in the same position as on the other side as well. So if you look at this, there are many other variations. I just decided, let me just put these ones and see. And we can have a discussion with Dr. Vuma and Dr. Shawa is on, and the rest of the team, and see what are their experiences with these sports. I must say, personally, I've only had with the experience with possibly the first two classical ones, your 3-port position, and I think the early 4-port positions. But the rest of these other positions, I have not had experience with it, and it will be quite interesting to hear what people think. So the other thing which I've noted is if you look at the current litigation stats, is laparoscopic litigation from laparoscopic procedures is fast approaching. Actually, at some point they actually they are becoming number one as compared to obstetric, like hypoxic ischemic encephalopathy and other obstetric injuries in terms of litigation. So it is very important for us to be able to know how basically to do our laparoscopy, to be able to get into your comfort zone, to know how best your port placement, your technique, and I think it is quite important for us to be able to. That is the only way we can reduce our exposure to litigation when we do laparoscopic surgery. Of course, we need to be able to adapt. Thank you.
Thank you so much for a nice presentation, Dr. Nzenza. Dr. Marere has asked me to assist with the chairing. She may be called in to attend to a patient very soon. Thank you for the presentation. I have two questions for you. The first one is, did you deliberately avoid to talk about the direct trocar entry, not the optical trocar entry?
I did.
Maybe
I did mention it. Yeah, the Haston technique.
No. So there's a direct trocar entry which is not the open Hasson technique. So it's almost, and then which then was modified to the optical direct optical entry.
Okay.
So where we just enter in with the trocar without any visualization with the camera and without use of the various need as well.
The only thing I can say from that, I did look at it. Yes, I didn't mention about it. Yeah, but in this case where, yeah, the direct entry where they just put in the trocar and then they put the camera like you described it. A lot of people are not comfortable with it, but one of the exponents of it who prefers it said it's better to do blind entry once than to do it twice. Let's say in a Ferris entry, you go in with the Ferris and then you go now again after insufflating, you go in again blindly with your trocar. So he feels that it's better to just do a direct once, and one blind entry is enough.
Yeah, I'm actually of the same sentiment. That is, when you do various need entry, you're actually going in blind, and then when you put the direct trocar again, when you put the trocar, you're going in another blind technique. So it's like two blind techniques.
Two blind techniques, yes. Whereas your direct open, you are just going in once and you insufflate once. Yes, correct. Yes.
And then in terms of complications like bow injury, vessel injury, what do you think? What do you think is the best technique?
I think from what I have seen, the optical with a direct entry with an optical, I think it gives you both the benefit. It gives you quite good vision, and it reduces the risk. Like for example, like in your Hasson technique, in your open as well in direct entry, so you are seeing exactly where you are going. But the only disadvantages for that one is resources permitting. Not every area does allow you to have your optical and your optical trocars. I think they're a bit more they're also expensive and they may not be freely available in resource limited settings. But failure to that, I would prefer the Hasson technique.
All right. No, thank you, Doc. So from the literature, really, the risk of injury and such complications, bow injury, or it's almost the same for all the techniques. Maybe the only difference with the direct entries is that you will be able to identify the injury immediately, as opposed to the blind techniques. You may not see that you've injured bow, or if it's a small laceration, you may not see it. But with the direct entry and the optical entry, you'll be able to identify those injuries immediately. All right, thank you so much. Dr. Ngwaru has raised his hand. Dr. Ngwaru, you can go ahead and make your contribution.
Thank you, Doc, for the presentation. And thanks, Mike, for that. It was a good presentation. I don't know, can you hear me?
Take them then.
Hello, can you hear me?
Yes, I can hear you. Yes, I can. Yes.
Use your head.
So I want.
Take those bicycles, they are gone.
We are having feedback. If you can mute your gadget if you are not speaking. Okay, Dr. Ngwaru, you can go ahead.
Yeah. So then,
Alex,
I don't know who's
Alex,
there.
please, you can mute your gadget, please. Alex, we can hear your conversation. All right. You can go ahead, Dr. Angwar.
Yeah, so pertaining to the ports, or the other variation, what's your comment of all those ports versus one port surgery, where you have one big pot and introduce instruments like what they do for V nodes? They actually have a pot, like a big pot where you put that. I don't know. What's your comment on that one?
So that one, I hope that is the same thing that I'm thinking of, where basically they put a bigger incision and then they open, and then it is got a custom-made kind of like diaphragm, which is inflated under, and when you, as soon as you get into the peritoneum, that it is got like a balloon inflated, and then you can then that diaphragm allows you to put in your pots through there. From the development, I will need correction from the senior guys. I think for that one, I think it was because they wanted to reduce the number of ports that are available. Number two, for removal of larger anatomical specimens, and especially those that may have a malignant potential. I think it was also coming from the fallout also of the what is it called, mocellata, I think, where maybe the mocellation, where they're thinking with mocellation you can actually seed your sarcomas as well. So I think it is a good way, especially where you are going in and where you're thinking of you are bringing larger specimens, anatomical specimens from your surgery. But otherwise, not otherwise routinely for other small, like your diagnostic, or we are doing a surgery where your specimens are smaller that you need to take out. I don't know if I'm getting you correct, but that would be my opinion.
Yes, you got me well, but maybe other people, I don't know what they think about that. And that thing that I wanted to find out was, did you look at patients' preference in terms of cosmetic, whether the port is at this level or at this level? Apart from the ergonomics, I think the patients, when you sell this laparoscopy, you talk about cosmetic. So at what level are they comfortable with cosmetic?
I think it's a bit of a tricky question, because for the patient, obviously they want as small a scar as possible, but also at the same time, the surgeon's comfort and the capability in terms of, because at the end of the day, the scar, yes, is important for the patient, the smaller the scar, but the definite management of the patient, also the clinical condition that you are managing, is important. So if the patient requests a scar where the surgeon is not comfortable, eventually the patient will end up having an extra scar when the surgeon is basically trying to get the best position for him to operate. So I think it's in the first place is the surgeon has to come out onto the patient to say, this is how he approaches, this is where he is comfortable with, so that the patient can make a decision or not. So I mean, it comes to the same issue where sometimes people wonder, is a mini laparotomy scar, let's say for a BTL, is one small mini laparotomy scar better than to do a laparoscopy where you end up with the three or four small scars around the abdomen?
Thank you for your response, Dr. Nzenza. Personally, I found it when I look at V nodes, so the natural orifice endoscopic surgery, when you look at V node itself and compare it with vaginal hysterectomy, I didn't really get the benefit or the advantage of doing that versus someone who's doing a vaginal hysterectomy, for instance. It really takes time. The instruments are crowded in that one pot. So the ergonomics there is very, very difficult. So for me, I felt that if you're going to go vaginal, it may be better to do vaginal hysterectomy than to do the V nodes. But definitely, I think with time, with experience, people have been doing it for a longer time, it becomes easier. Any other questions?
Mike, sorry.
Yeah.
No, I'm not talking about V nodes.
Yeah.
I'm talking about a single pot where you put a big pot in the umbilicus, and then you have all these instruments coming through there, so that you actually have one pot instead of one scar instead of yeah. So I think there've been studies that have been done, and I think patients have shown that they don't really like a big scar, anything above the bikini line. So so those are the things that you should also look in, and when you are trying to put your pots considering your ergonomics. Yeah. So the one big scar was actually not liked by many patients. They would rather have many small scars, but so long they're under the bikini line.
All right. Yeah, so definitely I agree. So the single pot surgery, even umbilical, I think there's two issues to do with the ergonomics with all those instruments going via one pot. It's likely to be very much difficult in terms of the ergonomics. Stefanietso, you can go ahead with your contribution.
Hi, good evening, guys. Thank you very much for a very good presentation, Dr. Nzenza. My contribution pertains to one, at the recent gynae endoscopy course or workshop in Cape Town, the take-home message on entry was that one must learn how to use both the Verus needle and the direct techniques. So if you know, the recommendation was basically on the easier cases that you practice both techniques so that you're comfortable with both techniques. The other thing that I wanted to mention was that there was no mention of Palmer point entry by Dr. Nzenza, which I think is actually an absolute crucial technique to learn, because of adhesions from previous, especially in patients that have midline incisions. I found that its Palmer point technique has actually rescued me quite a couple of times, where I got to a situation where after putting in the port, you then get to see how bad the adhesions are between the bowel and the anterior abdominal wall. Therefore, avoiding a situation where you go into bowel from your umbilical entry. The other thing that is quite important to look at is is your angle of entry or your entry technique in obese patients, because the versus thin patients. The last thing that I wanted to also maybe talk about is that in I don't know, I'm also quite in a learning curve with what I'm doing, but what I find is ipsilateral surgery is a lot more comfortable than if you put the port on the other side. But yeah, thanks. That's my contribution.
Thank you, Doc.
So yeah, thanks, Dr. Stefania. So I deliberately left the other entry points for your primary report, like the Palmer. What's the other one between the umbilicus and the xiphoid?
That's the 1 point.
A 1 point, yes, the 1 point, yes, yeah. I did because I just wanted to go basic and at my level. And for me, like I said, it was to remind me, obviously, and to refresh for you guys. A patient who is going to need, from at this point, a Palmer or only 1 point will be someone that maybe I would want to go a different approach. But absolutely, it is the patient selection determines how you are going to approach that patient, especially if there's previous surgery where there's potentially adhesions onto your anterior abdominal wall. And obviously for obese patients, where the umbilicus is far away from where you really want to be. So it's another factor that has to be, but I felt at this point, I don't think I'm qualified enough to talk about it. That's why I deliberately left the Palmer and the Lee 1 point, and just to focus on the basic in a normal setup situation, and maybe later on when I have a bit more experience and I've read a little bit more, I'll revisit and re-update it, and we can talk about it, or maybe another colleague can take it up.
That's okay. Thank you, Doc. Do we have any other questions?
Yes, Dr. Ngwaro. Can I don't seem to know how to raise my hand on this thing.
It's okay, Dr. Boma, you can go ahead.
Yeah, just to a few comments. Thank you so much, Dr. Zeza, for the wonderful presentation. Obviously there's the theory, and then you obviously then evolve your technique as you go and you find what is suitable for you. My own view is obviously the question about two blind entries. Any entry into the abdomen, even laparotomy, is blind. There's never a visual entry to the abdomen. So that's for me the standard. Now it's better to have a 2 millimeter hole where you do your varus needle than to have a 10 millimeter hole in the bowel. The other one you can observe, but the other one obviously you have to abandon the surgery and then call the surgeon. It's better if you do it through and through the anterior bowel and you come out on the other side. Sorry. Yeah, so you go through, so that's what for me, one of the things. So my primary thing is I always do a varus needle first and then a visual entry later. And but obviously, as you see, the Cochrane collaboration view was that it just depends on this, because the problem is not the technique, is this surgeon. The safety is based in the surgeon. So we can try all these various things, but obviously, as you Dr. Sfanyos was talking about, you always need your in some cases where you cannot go in, you always need to try other techniques so that you can actually progress and do the surgery. And I would agree that I prefer ipsilateral. I do ipsilateral. I always find the suprapubic very awkward. Almost your hand is hanging over like this, but with my elbows by my side, I can operate 2, 3, 4 hours, especially when you start doing deep endometriosis or kind of surgeries where you want to operate for longer with more comfort. And I think also in terms of your positioning, one of the things is that obviously you are equally unbalanced if you have a suprapubic port. You are almost like facing into the pelvis. The other one, you're almost like lateral. But obviously that also leads to occupational injuries. You will definitely, in the long run, you need to protect your back and your posture. So, but I think one of the biggest thing is that with time, your complication rate goes away. You basically become become automatic in everything that you do, and then your risk of entry injuries and everything goes down the more you do. So the question is just to be initially to be aware, but always to then try and find what position, which stroke placements actually are comfortable for you. Thank you.
Thank you, Dr. Vuma. So yeah, I think the best experience is the best teacher. You will always find which one is the best method that you can use, and as much comfortable as you can to be able to do those long procedures. Any other questions? We are just past 7 p.m. We can have two more or so contributions. Yeah, you can go ahead.
Yes. The one thing that I wanted to ask is it possible that one of our experienced surgeons, like Dr. Vuma, shares a video on direct visual entry, because and the layers that you go through, because I think that might help a lot of us. The other thing I wanted to ask is there's nothing wrong in presenting something that you have not tried or attempted, because then when it's easier for experienced surgeons like Dr. Vuma and Dr. Shava to comment on the presentation in terms of something that you have not attempted, because then when you go back and attempt it, you've got there's some basics also thrown at you, so that when you go and attempt it, you've got tips from how to go about attempting it. Thanks.
How asifanya so answers saya no behind I won't I can't do not say.
Dr. Zeza. Yeah, but anyway, thanks. No, I was just saying for future.
Yeah, anyway, sorry, I had to go on to the other side, guys, but yeah, no,
my
true.
apologies.
No,
It's not a direct attack. I'm just saying that it would have been nice to discuss things like Palmer point entry, because
true.
You're going to run in. I mean, I've also, when I attempted it the first time, I was by myself,
Yes.
and there's the things that are worth mentioning, like examining for hepatosplenomegaly, and the books talking about putting an NG tube and all of those things. And those things would have been nice if they come out now, so that if one had to go and attempt Palmer point entry, they would do that with some knowledge of how to go about it. It's not a personal attack. Thanks, guys.
No. It's not an issue. Maybe next time I'll look at it, maybe, or someone may look at anterior abdominal or anatomy and just in that way to look at possible pitfalls and how to go about it. Yeah. I mean, just I think that would be a very good way of looking at it, especially your Liwang and your Palmer point. Yeah.
No, that's fine. Thanks.
No offense, bro. No offense.
All right, thanks. Bye.
Yeah. Sure.
All right. Thank you so much. Do we have any other burning questions? Chipo, do you have any information for us for next week and the future presentations? You can please give us an update on that.
Thanks, Michael. I'll send the message. It's on the group.
Okay.
Yeah. Thank you, Doc, for the interesting presentation.
Thank you, everyone. Thank you.
Thank you, Dr. Vuma, for directing, and the colleagues. Thank you so much for attending. We'll see you next week.
Thanks. Good night.
Thank you. Good night.